Hello and good afternoon, everyone. My name is Tacy Silverberg-Urian. I'm a certified hospice and palliative care nurse. I'm also the chair of Essex County COYL Task Force and the president of the Northern New Jersey Provisional Chapter of Hospice and Palliative Care Nurses Association. I founded Advanced Choices because through my years of face-to-face and hands-on experience in end-of-life care, also known as hospice and palliative care nursing, I recognized how unprepared most of us are in expressing what types of medical interventions we want or don't want, or what is truly important in the end. I've met with families that were well prepared with advanced directives. They were calm and they knew exactly what their loved ones wanted them to do. And the others who were not prepared and had no clue, they were distraught, angry, confused, afraid, and anxious. I truly believe that talking about end-of-life wishes helps create the opportunity for a more peaceful day. This webinar was co-created with my colleague, Caren Martineau. She's the founder of Revival.com, a death literacy content platform and home for Dying to Know Day, America's annual death awareness campaign.
Thanks, Tacy, for the introduction. Hello, everyone. Thank you for joining us today. I have to tell you, when Tacy invited me to collaborate, I got really excited because as a former creative director and producer, I've spent most of my career creating identities and communications for entertainment brands, celebrities, fashion designers, and lifestyle products. And like so many other baby boomers, culture change is hardwired into my DNA. I'm part of the generation that created cultural revolutions like Woodstock, Watergate, civil rights, parenting, aging, and now it's time to do something about end-of-life education. You know, after learning how to capture magic in a bottle for others, I decided to use my skills to launch an edutainment platform that addressed the ending of life. It was my way of gift wrapping a difficult conversation and an inevitable event. Let's start out by asking you two essential questions. And please use the chat function to respond. One, we'd love to know, why are you taking this webinar? Is it for yourself or is it for your profession to help others? And part B of that question is, what's the most important thing you want to know regarding an advanced directive, regarding planning an advanced directive? Okay? I'll give you a moment. You can just keep answering those questions as I go on. So if you're experiencing any resistance or fear around preparing an advanced directive, just know that that is totally normal. Our culture never taught us how to talk about mortality. Getting old and dying simply went against the grain of American progress. So we, as a culture, ignored what we couldn't control. But now, as it turns out, we've entered into a period that is being called the longevity economy, because medical technology has found a way to allow us to live longer and die slower. This progress, if you haven't heard, has made immortality the next big moonshot for scientists. Pretty incredible. But understand that it's going to take a while for the biologists, the technologists, the ethicists to figure that all out. We're going to make plans and do what we can to do our advanced directive because it's really valuable and important. So here's why. Having a plan reduces your own anxiety. It protects your loved ones from facing major decisions without guidance from you. It avoids placing an unnecessary burden on already stressed out healthcare professionals. It allows pre-considerations of ethical dilemmas that may arise. So here's what you're going to walk away with today. You're going to know what an advance directive is, who benefits from an advance directive, when it becomes useful, why you should prepare an advance directive, and how to complete your advance directive. So one thing that you should know, we will not be filling out your advance directive today during this webinar. We're going to be walking you through because our goal is to show you how to do this on your own over the next few days or weeks, as soon as you're ready. We want to just help you become familiar with the document so that you can give it enough thought and reflection before completing. That's what we call death literacy. Now, you may be more familiar with the term living will than an advance directive. They're one and the same. The 5 Wishes document is the most widely used legal advance directive in America, and it's often called living will with heart and soul. So over the next 30-ish minutes, we're going to walk you through the 5 wishes so that you can comfortably complete it on your own with confidence. There are 2 reasons why we're doing this webinar. First, the reality of COVID-19 has many people facing their mortality. It's random and unpredictable, and because of that, every adult now should know, regardless of their age, that they need to be prepared. And secondly, during the month of April, National Healthcare Decisions Day and the Conversation Project partner with national and local organizations to focus on the importance of completing your advance directive.
One such organization is the New Jersey Healthcare Quality Institute. And as the Essex County Task Force Chair of COYL, which is short for Conversation of Your Life Initiative, we're actively creating educational programs around end-of-life planning. Collaborating with Caren has allowed us to bring a different vocabulary to this topic, something we believe offers you a richer learning experience.
But I know no one wants to talk about end of life. But through personal experience, I learned that talking about the uncomfortable long before the end occurs, long before any crisis, is to everyone's benefit. And before this pandemic, end of life wasn't a subject matter that people discussed, unless, of course, there was a diagnosis or an elderly relative or friend involved. COVID-19 has forever altered the way we go forward. By acknowledging that life and death coexist in the present moment, we're learning that this topic is really worth discussing when you are very involved and busy doing life. So in a peculiar way, this awful virus turned out to have a silver lining. When the time comes, and you know it will, normalizing these end-of-life conversations delivers a gift to those who will be caring for you.
All right, so let's begin by reviewing wish number 1 on page 4. Hopefully you've downloaded your free 5 wishes document from Aging with Dignity. And here we go with wish number 1, choosing a healthcare agent. Now you might ask, why do I need a healthcare agent? Your healthcare agent, sometimes also called your healthcare proxy, will be the person who speaks on your behalf if there comes a time when you're not able to speak for yourself. This could be your partner, adult children, best friend. It could be whoever you believe will be the most capable of honoring your wishes. Let me give you an example. My sister-in-law is dying of cancer, and she told me in confidence that she did not want her husband, my brother, to be her healthcare proxy, because she knew that he did not agree with what she wanted, and instead she chose her sister, who honored her wishes to stop medical treatments at the right time and be transferred to a hospice facility where she died a peaceful death. Another example is an elderly female who I met with the family. She lived in an assisted living facility. She was bedbound. She suffered dementia. Her nutritional status was failing, so her physicians were recommending an artificial feeding tube for nutrients. And based on previous discussion, her two daughters contemplated hospice, which is a type of service and philosophy focused on comfort. Together, we reviewed their mom's advance directive, and it clearly stated she did not want artificial feeding or antibiotics. But the daughters went along with the physician's orders, and they started her on tube feeding, which eventually caused congestion, and it made it difficult for her to breathe. So they discontinued the feeding, but continued a course of IV antibiotics. This required a longer hospitalization, daily blood draws, and after about an additional week, she was transferred to a hospice facility where she died only 24 hours later. This was not the ending she wanted. These two stories highlight the importance of designating someone who can make decisions for you and honor your wishes when you're not able to advocate for yourself. Now you might be thinking, can I have more than one healthcare agent? The answer is yes, but make sure they're on the same page with carrying out your wishes. It's also a good idea to name a backup if your primary choice is not available. Then they would be reaching out to that second person. Many people have said they don't have someone to represent them. If this is the case, make sure you send a copy of your 5 wishes to your primary care provider and request a follow-up call or a televisit to discuss. And if you end up going to the hospital, remember to bring a copy with you for your hospital child. Now, wish number 1 continues on page 5. Here, they will show you 11 types of medical decisions your healthcare proxy would handle. For example, there are choices about starting or stopping medical interventions like tests or surgery. Mind you, these are just common examples. You may think of something that isn't listed here. Add that note to the blank space provided. And if you don't want your healthcare agent to do something listed on this page, just cross it off. Okay, we're moving on to wish number 2 on page 6. This section begins with asking you to think about life support and what that means. Life support includes the use of any medical procedure, device, or medications to keep you alive. For example, a feeding tube, a ventilator, dialysis, CPR, blood transfusions, antibiotics. Wish number 2 asks you to think about the kind of medical treatment you want or don't want, or how much or how little you want. I'm just going to go through some definitions. A feeding tube administers fluid and nutrition. It's a tube that's inserted through a surgical abdominal incision or through your nose into your stomach. A ventilator is a machine that administers oxygen. A large tube is inserted through the mouth and down one's throat to the lungs to aid with breathing. Dialysis is a machine that filters out toxins and waste when your kidneys begin to fail. A shunt is surgically inserted in the arm, which is then connected to a dialysis machine. CPR is cardiopulmonary resuscitation. It consists of chest compression and mouth-to-mouth resuscitation. Blood transfusions are used to treat anemia or low blood count, and antibiotics are used to treat infection. Use the blank space to voice your opinion about what would be okay and what is too much, or add things not listed, things you feel are unnecessary or aggressive treatment. Your decisions will be based on many factors, like your religious or personal beliefs, or even your health status. In the midst of our current health crisis, I'm hearing tragic stories from my colleagues on the front line. Because many medically fragile and elderly patients do not have an advance directive, the healthcare team does not know what the patient wants, so they have to perform aggressive medical interventions even if they did not want it. Believe me, such procedures can be traumatic and futile. What makes this even more difficult during this crisis is that these healthcare workers cannot consistently share a moment to sit with loved ones, offer support, or provide a gentle touch or hug. My colleagues are agonizing over the what if. What if patients had been able to prepare, have these conversations with loved ones about what was important to them? Certainly, their quality of life would have been better, and families would not be feeling so terrible and conflicted. Wish number 2 continues on page 7. And here, they present these 3 end-of-life scenarios. The first one, close to death. Second, in a coma and not expected to wake up or recover. And the last one is permanent and severe brain damage. Now, for each of these scenarios, you will have to decide what you would want by checking off one of the 3 boxes. These are the 3 choices. I want to have life support treatment. Second one is I do not want life support treatment, and if it was started, I want it stopped. Or number 3, I want to have life support treatment if my doctor believes it can help, but I want my doctor to stop giving me life support treatment if it is not helping my health condition or symptoms. So, for example, if I were in a coma and I wasn't expected to wake up or recover, I would have to decide either 1, 2, or 3. Have life support, stop it, or I want to have life support treatment if my doctor believes it will help, and if it's not helping, then stop it. So at the bottom of the page, you'll see a blank area where you can insert your thoughts or a condition not mentioned here. Things like end-stage dementia, heart, or renal failure. Now let me share another true story of why it's important to document one's advance directive. I was requested in the ICU to meet with the family of a 95-year-old woman with heart failure, diabetes, and end-stage dementia. And she suffered a CVA, stroke. She had been intubated and placed on a ventilator, and her kidneys were beginning to fail. There was no advance directive in place, and she had never spoken with her family about what she wanted at the end of her life. The family was conflicted and felt she would not have wanted to be kept alive on the ventilator. This scenario would have gone differently had there been an advance directive, especially if it indicated a do not resuscitate order. If there was a DNR order, the healthcare team would not have intubated her or placed her on a ventilator or even considered dialysis. This family's anguish was tragic. They had no idea what to do because she left them without instructions. Unfortunately, as a hospice liaison, I saw this happen all too often.
But I want to take a little breather right here before moving on to wish 3, 4, and 5. And in this little period of time, I'm going to tell you a personal story, which is my story. When I first began advocating for death literacy, my family and friends looked on in absolute horror. They did not understand what had come over me. And frankly, it really wasn't obvious to me, although I was driven. Only in hindsight now do I know it was my collective experience of death that brought me here. So I was 22, the first time I had a up-close death experience. My mother was taking my little sister to school on a snowy morning. She had a car accident. She died instantly. And my sister suffered a very long and protracted recovery. Somewhere in the messy aftermath, my dad asked me to clean out my mom's closet and things, while he buried his emotions and just moved on. There was no discussing what happened. Let's fast forward 30 years. My dad's second wife dies peacefully in her sleep. After about 6 months, I gently broached the topic with him about what were his end-of-life plans. And despite his experience and his rapidly declining health, he wanted no part of this conversation. He said, "Not my problem. I'm going to be dead." So, after that disturbing conversation that I had with him, I began conspiring with my brother to put as many things into place despite his denials and his blocking of any kind of action. And in the end, really, he endured many aggressive interventions and multiple hospitalizations simply because he just didn't want to talk about death. That left a big emotional burden on my brother and I, just the whole process. And what it did also is it just negated any positive memories that we had because we were just so burdened with the negativity of it all. So here's the thing. I knew I didn't want my daughter and my son to go through a similar experience, but actually didn't do anything about it until I experienced 2 other bad deaths. Those experiences had me looking the dragon in the eye and feeling the heat. And that was the prompt that had me think about launching a website, Revival, that was dedicated to end-of-life conversations. That was a gentle entryway, a portal into beginning a conversation. Not at the end, but long before the end. So the first time I did my advanced directive was in 2015. And I remember thinking, why is this so hard? First of all, it's hard to think about what the possible scenarios you would confront in a crisis, in a medical crisis. And second of all, I had absolutely no medical training. So I didn't understand the terms and I didn't understand what to put down. That's why I became an advocate for death literacy. It was my way of slaying the dragon. And frankly, this webinar is being produced as a way to help other people slay the dragon. Now, maybe a month ago, I just revisited mine after 5 years, and I can tell you it was really a big relief knowing that it represented me now in the moment.
Thank you, Caren, for sharing your personal stories. I bet most of us can relate to them. All right, guys, so wishes 3, 4, and 5 are on pages 8 and 9. They focus on personal, emotional, and spiritual needs. In this section, all you have to do is cross off any of the actions you do not want your loved ones to do. Wish number 3 is about comfort. It includes things like how you want your symptoms managed, things like pain, depression, nausea, or if you want your favorite music to be played, or if you want to be massaged with warm oils. Remember, in these sections, read each intervention and just cross off anything that you do not agree with. Wish number 4 is how you want people to treat you. For example, do you want people present with you at all times? Do you want your hand held? Do you want prayer? Do you want to die at home? Read each of these actions and cross off anything you do not desire. Wish number 5 is what you want your loved ones to know. For example, I want them to know I love them and forgive them. I want them to respect my end-of-life wishes, even though they may not agree with them. This wish also includes your funeral or memorial wishes. In this section, all you have to do is cross off any actions you do not want your loved ones to do. Like the previous wishes, there's a space on page 9 to write in any other wishes that may not have been addressed yet. Feel free to write them in here. Okay, we're almost done. This is a reminder to please use your chat function to submit your questions. Now let's turn to page 10 and 11. In order to make this a legal document, you must sign it, then have 2 witnesses not related to you sign. It cannot be that healthcare policy. And you do not need to get it notarized or signed by an attorney. This is the beauty of this form. Once you sign it, and you have 2 witnesses sign it, your advance directive document is legal. Next, you're going to want to make several copies. One for you, one for your healthcare agent, family members, and your primary care provider. Now that you're done, it's important you schedule time to review your wishes with your family and healthcare provider. Don't forget to complete the wallet card on page 11. This will inform others where you have placed a copy of your 5 wishes. Do not store your 5 wishes in your security safety deposit box. Make sure it's somewhere accessible.
Some of the common questions that come up about this are, what if I already have a living will or a durable power of attorney? Well, best practice says that you should revisit your advance directive every 5 to 10 years or after a major life event such as a marriage, a divorce, or an illness. Once you've completed your 5 wishes, get rid of any old paperwork so there's no confusion. Another question comes up often is, what happens if I change my mind about who I want to designate as my healthcare agent, or I want to make other changes to this document? All you have to do is simply write the word revoked in capital letters or large letters across the areas that you want changed, and then insert new names, date and initial it. You're going to make changes. Again, just initial and date it. And that's it. Congratulations. That's the whole 5 wishes. You now have a completed advance directive.
Another common question I'm asked is about palliative and hospice. What are they? Can I include them in my 5 wishes advance directive? And yes, of course, you can enter these under wish number 1. This is a decision you can authorize your healthcare agent to choose. Most of you on this call, I'm going to give you an explanation anyway. Hospice is also known as comfort care. It's provided mostly in the home setting. However, it's also provided in hospitals, assisted living, and skilled nursing facilities too. It's a philosophy of holistic patient-centered care provided by a team of professionals from a hospice agency. The focus of hospice care is to provide emotional, spiritual, and physical support and to aggressively manage pain or discomfort. Management of symptoms is also known as palliative care. Palliative care is a specialized medical care for people living with serious illness. It focuses on providing relief from the symptoms and stress of an illness at any stage of the illness, not just at the end of life. Palliative care is an extra layer of support and can be provided along with curative treatments like chemotherapy, radiation, or blood transfusions.
So we've given you a lot to consider. Take whatever time you need to digest this information and talk it over with your family and close friends. Should questions come up later, of course, we're here to support you. We're going to be here through your completion of this document. So, there's a couple of questions that came up with chat. Let's answer those, and discuss some other things that are floating around. So one question says, this is from Marie. Caroline, I have a living will that's outdated. It goes back to 2005. Do I need to update it? Yes, you do. Who you were and your circumstances in 2005 are very different than what's happening now. So yes, the advice is definitely update it, revisit it, and see what has happened in your own life to help you to transition from where you were to where you are now. Another question is, and this one is for you, Tacy. Can this document be used to add a patient-directed end-of-life wishes, the desire to stop feeding and hydration as a way to speed up the natural process?
No, I don't think it really, I have a problem with the word speeding up, but I think what I prefer to address it as is that we're just allowing the natural process to occur. Many of us don't know that with end-stage dementia, one of the natural things that happen physiologically is that they forget cognitively how to swallow. That's part of the natural process of end-stage dementia. Therefore, inserting feeding tube, which is an artificial way of presenting or providing nutrients, is something that will prolong that person's life, but also it may prolong their suffering. And again, you have to have these conversations with the person prior to their dementia to really understand what it is that's important to them in the end. Would it be important for them to continue to receive these artificial nutrients if they are unable to swallow, if they're unable to get out of bed? There's so many variables to consider when making these decisions. But really to answer that question, I would really try to, get to the essence of that person. Who was that person before they got killed? Would it be someone that if they could speak their mind now, would they be asking for the feeding tube or the ventilator, or would they be asking for you to not intervene?
Thank you. So there's a couple of questions here about pulse clarification. So I'm going to read those. Tacy, again, if you would address. So Frederic is asking, is it recommended to have a pulse form if you already have an advance directive? And if somebody has both, does one cancel out the other? And I'm going to add to that something from Mary Ellen that says, can you make a comparison to the pulse after or the other than it's a medical order? So can you clarify this pulse thing and how it differs from an advance directive?
So the pulse in New Jersey is a state form. It's a state form, and the acronym for pulse is Practitioner Orders for Life-Sustaining Treatment. And this would take precedence over an advance directive if you are being treated in a hospital setting, because it becomes a physician's order and therefore has to be followed by the physicians in the hospital. Now, I can only share my experience with pulse and advance directives in certain hospital settings that I have worked in. Oftentimes, an advance directive, unless you have a very strong family advocate, speaking on your behalf to bring it to the medical team's attention. Oftentimes those advanced directives are just stored in the chart. They're not really looked at to see where this person's wishes were. But on the other hand, a pulse, because it is a physician's order, is viewed much differently in the hospital setting.
So what you're saying, in essence, if I understand this correctly, is that you have two documents. An advance directive is important and a pulse is important, and they should duplicate one another in what they're stating?
Yes. Yes,
okay.
they should be in the pulse. You're going to name them the healthcare policy, as well as what type of medical treatment, life support that you want for them. It's very specific. They also ask you what your goals are in the pulse. Oftentimes I've seen people with serious illness have their goals listed as comfort. So therefore, within the pulse, they'll also address the do not resuscitate order. Now, the pulse will take precedence over an advanced directive in the hospital. That was the question.
Yes.
But not everyone will have a pulse. So, for instance, because I don't have a serious illness, I would not have a pulse. But I would have, and I do have, my advanced directive. The pulse are really specifically designed for people living with serious illness. And that's a conversation that the person has with their healthcare provider, whether it be a physician, it could also be done by a nurse practitioner and a physician assistant.
So if I'm going to interpret this correctly for a layman, one would do their advance directive, their 5 wishes, right? Because it's a very gentle way of having these conversations and giving you prompts to consider what are your options and what are your wishes. The advance directive is also a very good document to open up the conversation with your family, because as you're considering these topics, and they're not easy topics, as you're considering them, you can then discuss this with your family, because it is about you. And this is what you want. So, if you start with your advance directive and then you try or you do duplicate that into your pulse, should the situation warrant, then it seems that you have a pretty foolproof fence around what you want to do with your end of life. Would that be correct? Would that be a good interpretation?
Yes, absolutely.
Okay.
The main takeaway I have to say is really the communication that you have with your family in terms of what's important at the end really is such an important conversation to have, because so many different types of scenarios may present themselves at the end, and family, it may not have been captured on your advanced directive, but if your family knows exactly, what is important to you, it would be easier for them to interpret as to what actions you want or not want at the end.
Let's go back to COVID-19 for a second, because in these unprecedented times, people are talking about death, and they have not spoken about death. And what our news feeds, anything that we watch, we're dealing with this topic all the time, and we are witnessing unrealistic and unreasonable tragedies, loss of life, and such a massive scale. So if you've been trying to open up this conversation with your family before this happened, before the pandemic, and you hit a brick wall, because I can tell you, I hit a brick wall. I've been chipping away at it for years now. Now, after a while, my family started to break down and to say, okay, here we go. And they softened up. So actually we were in a really good place before the pandemic hit. But right now, if this is the first time that you're broaching this topic, this is the perfect time to do it because you don't have to explain why you're doing it. What you want to communicate is that you don't want your family to suddenly be dealing with your loss of life or your spouse's or your partner's loss of life. It just happens in the blink of an eye. And there they are in a hospital dying. And you haven't said the things that needed to be said. And you never spoke about what it is and how you wanted to be treated or they want to be treated. When the end came, the doctors are doing the best that they can, but they are morally torn apart because there's nothing for them to guide them to say, what should we do now? And they're scrambling to get the family on the phone or to get them on FaceTime. So really leverage this moment, this horrible moment of this pandemic, become death literate and to invite your family into this conversation. They should understand everyone is at risk.
I'm going to add a little bit to that because, having worked in the hospital setting with these families at the end of life, it really truly is a gift if they have an advanced directive because this gives the family kind of the roadmap as to how this person really wanted their end of life moments to end, versus the ones that come unprepared with the advanced directive. And, the anguish that each family feels in trying to make the right decision. So to view it as a gift for the family members is another approach that I've seen work and is successful.
I have one more question here before we close out. So Frederic's asked, is there an instance when an advance directive would not be honored because it's outdated? For example, if it's not updated every 5 years, does that make it invalid?
No, there's really no expiration date on an advance directive, as far as I know. And as long as, the parties involved are still in agreement with what this person wrote down, whether it was 10 years ago, like prior to dementia, when they were competent, if they wrote those wishes, then they should be respected.
Remember, we're here to support you through the process. If you have any questions, medically directed questions, please send them to Tacy. Here's her email address. And if your organization would like a copy of this presentation or you'd like to talk about other things, you can email me at Revival, and follow us on Facebook and Twitter and Instagram and sign up for Revival's occasional newsletter on our site. That would be great. And, great. So we hope you found this webinar helpful and are comfortable taking the next step of completing your advanced directive, your 5 wishes. Don't wait too long. And in closing, I must thank Aging with Dignity for making this 5 wishes document available for free for participants, and to the New Jersey Healthcare Quality Institute for helping distribute this webinar to COYL communities. So to everyone, thank you again for joining us. Be safe. Stay healthy.
Thank you, everyone, for joining us.